Just a few words of introduction. I'm Jack Biggane, and I'm president of the Mollie Biggane Melanoma Foundation. And this is the 5th year that we're presenting this educational effort on melanoma. This morning, doctors Anna Pavlick and Jed Wolchek, Jim Goidos, and Janice Mayhart have volunteered their time to explain the latest from the field of the medical field of melanoma. Tom Telford is also going to spend a few minutes talking about his battle with melanoma. I want to thank Dr. Scott, who's the president of Adelphi University, who allows us to use this facility at no charge. And also, I want to thank Milo Lanou, who's just up here testing the microphones. He's the manager of this facility, and he's made it very easy for us to put this together. Before I introduce Dr. Anna Pavlick from NYU, she's going to be the program host, I just wanted to show you a 30-second public service announcement that our foundation has put together. Because May is Melanoma Awareness and Prevention Month, we've created this 30-second video for all of the, not all of the taxi cabs, but 6,500 taxi cabs in New York City, ABC TV, Cablevision Channel 12, Channel 10, and Channel 55. There's one other PSA that's been created by another foundation that we're collaborating with. It's called the Melanoma Research Alliance and the Danny Fund. And Danny was a guitarist in Bruce Springsteen's band. He passed from melanoma last year. And they've created this PSA encouraging people to vote for $250,000 in research money for melanoma. So after you see this, and before you leave this afternoon, we have a PC set up at the front door where you can put a vote in, and you can do this throughout the month of May. And it's, for a good cause, $250,000 of research money for melanoma.
Good morning, and thank you everyone for coming out on a Saturday morning. We hope to make this a little bit shorter, an educational, pleasant morning for you. I want to thank the Maggie Biggane Foundation for organizing this. This is our 4th year doing this, and hopefully the 4th of many more. So this morning, I'm going to be the host for the morning. I'm going to give the opening lecture about looking where we've come with melanoma and where we're going, which will be a brief overview, followed by Dr. Goidos from the Cancer Institute of New Jersey, who's going to be talking about surgical aspects of melanoma, followed by Dr. Wolchek, who's going to speak on immunotherapies that are changing the way we treat melanoma patients, and then finally, Dr. Janice Mayhart from Cancer Institute of New Jersey as well, is going to talk about some of the new and exciting targeted therapies that we're using to treat metastatic melanoma. And then finally, we'll have one of our melanoma survivors, a patient of Dr. Wolchek's, come up and tell his story about how he survived melanoma. And then finally, we'll end with a question and answer period. So my name is Anna Pavlick. I'm the director of the NYU Melanoma Program. And I'm here to talk to you about where we've come with melanoma and where we're going, because as I see it, within the last few years, we've really made some amazing strides with learning how to personalize more treatment for patients by really evaluating their tumors and deciding which is the right treatment for patients. So I think we're all old enough to remember these advertisements. Talking about using baby oil to improve your suntans, and tartan never let you tan, it never lets you burn. And I would venture to guess that there's not many of these ads left. It's more stay away from the sun. Wow, you didn't like me to talk about that slide? Okay. All right, so we'll talk about what is melanoma. Melanoma is a skin cancer. It's one of 3 skin cancers that can occur. It is clearly the most deadly form of skin cancer, and it's expected that approximately 69,000 people in the United States will be diagnosed with melanoma in 2009, which is a really scary number. Essentially, it's about, if you break that down, it's 1 in about 50 people are going to be diagnosed with melanoma. It's the 5th most common cancer in men, 6th most common cancer in women. However, it is the most common cancer in women between the ages of 25 and 29. And that's a very scary statistic, since these are women that are young and having children and having families, and they're being struck with cancer. Where does it occur? Well, it occurs anywhere. Most commonly, it can occur on the back, generally in men, legs in women, but melanoma can really occur in any place. So, how was melanoma first identified? Well, in 1787, a surgeon by the name of John Hunter identified a tumor he had never seen before in a patient and called it a cancerous fungus because it had spread all over the place and he had never seen anything like that. It was then given a name in 1804 and finally called melanoma. And then in 1820, the same person who described this cancerous fungus as melanoma made a link with this tumor to the intensity of sunlight exposure, and therefore the connection between sun exposure and melanoma was first documented. And then in 1892, Dr. Snow did the first elective lymph node dissection because after looking at many patients who had melanoma and operating on them, he felt that tumors spread most commonly to adjacent lymph node areas, and therefore when someone was diagnosed with melanoma, he went on to perform a lymph node dissection. And then in 1907, Hanley first looked at how do we operate on melanoma? And wouldn't it be important to get more clean tissue around the area where melanomas occurred to try to make sure that it didn't come back in the spot where it started? And then finally in 1985, dermatologists at NYU developed a screening tool called the ABCDs of melanoma, which I'm going to go through with you. And then finally in 2004, the same group of dermatologists added an E to the ABCDs, so now it's ABCDEs of screening. And this is a nice screening tool for patients to use in order to identify moles that may become suspicious. So what are the risk factors? Well, clearly, if you have one melanoma, you are at increased risk of developing a second melanoma that's not associated with the first melanoma. If you have a family history of melanoma, meaning first-degree relatives, mom, dad, sisters, brothers, that's going to put you more at an increased risk. If you've had excessive sunlight exposure, bad scalding sunburns as a child, a lot of men we're seeing now who served in the war who never thought to use sunscreen and always had the shirts off their backs were coming in with melanoma. If you have fair skin, ideally we tell people if you've got blue eyes, fair skin, and strawberry blonde or blonde hair, you're at an increased risk. And again, these are the skin types that frequently burn, and patients will have a history of being a lifeguard and will have a subsequent history of sunburns. So this is what melanoma's been doing, and this is why it's so important that we work hard and do research to find an answer, because melanoma is skyrocketing at a very scary rate. I have the last bar here looks at the year 2000 where it's 1 in 74, and here we are only 10 years later and now the risk is 1 in 50. So essentially, if we keep this pace, we're going to look at pretty much everyone being diagnosed with melanoma at some course in their life. So these are the ABCDEs, and I'm going through this because I think it may be something that people may not know about. It may be something that may be useful for you to take home. When we look at a mole, moles are supposed to be symmetrical. So A stands for asymmetry. And as you can see, if I can get a pointer here, you can see that this is a nice round border here. However, the pigment is clearly blurred and there's no symmetry to this mole. So that's a mole that's suspicious. It's not necessarily melanoma. However, it's something that should be brought up to your dermatologist. B is border. Border should be crisp and clear and very precise. As you can see on this mole, it's a cloverleaf type of mole, and those have very irregular borders. Again, this is a suspicious mole that needs to be evaluated. C is for color. Moles are supposed to be one color. They can either be red, where you can get red cherry angiomas, you can get blue nevi, or most moles are most commonly brown in pigment. This mole, you can see it's dark, it's got blackness in it, it's light brown, and it's got an area of red. Again, multiple colors, things that need to be evaluated. D is the diameter. Moles shouldn't be large. Large moles are probably not good. How big? We try to tell people that if your mole is bigger than the head of an eraser, it's probably something that needs to be evaluated. And finally, E doesn't have a slide, but E means evolution. So patients are born with moles. We all have moles, at least most of us have moles. And over the course of time, if you notice that a mole changes or evolves and goes from a very small mole or a small nevus into a larger lesion, then this is something that, again, should be pointed out to your dermatologist. And so why is melanoma an invasive type of sneaky cancer? Well, because melanoma just doesn't grow on the surface. Melanoma, as you can see through this, melanoma grows downward. It grows vertically. And that's why when we do biopsies, our biggest concern is not how big is it on the surface, but how big is that mole in depth. And depth of a melanoma is always prognostic of how people are going to do. So once you get diagnosed with melanoma, then what do? Well, first you start out with a biopsy, which is usually done by a dermatologist, and that's usually a skin or an excisional biopsy, meaning that the dermatologist will cut a piece off and send it to the lab. Once the diagnosis of melanoma is made, depending on the depth of the tumor, patients will either then undergo a surgical procedure with their dermatologist or be referred to an oncologic surgeon such as Dr. Goidos and undergo a wide local excision. Now again, depending on the depth of the melanoma, surgeons may or may not offer you what's called a sentinel lymph node biopsy. And a sentinel lymph node is the first lymph node that we believe drains where your melanoma is. And how do we identify that? Well, we identify that by knowing anatomically where lesions can drain. And we'll take some radioactive dye as well as some blue dye and inject the area where the mole is. And this is the radioactive portion that shows here, if I can get this area is where the melanoma was injected at the surface. And you follow the dye, and this is done in the radiology suite. And so we take a picture and see which is the first lymph node that will light up. And so the surgeon knows how to plan his surgical procedure, which lymph node basin is he going to need to explore when he's doing the excision. So once the surgery is done, we then sit down with patients and go through how do you stage your melanoma, because everybody wants to know what stage they are. And something that's been pretty common to me is that patients confuse staging with phases, and phases mean clinical trials. Stages mean what level of melanoma you have. And so when we stage a melanoma, stage 0 melanoma is a melanoma that never gets to see a surgeon, never gets to see an oncologist, and is taken care of routinely by the dermatologist because it's referred to as a precancer. It's a melanoma in situ. It's a mole that's starting to change and does contain cancer cells, but it's only on the outer layer of the skin and hasn't broken through and become invasive. So these are melanomas that we really don't worry too much about. Stage 1 melanoma, and I'm going to go through this quickly because this is much more than you need, but stage 1 melanomas are, again, the melanomas that are very, very small, less than 1 millimeter, taken care of by a dermatologist, and it also has no ulceration. What's ulceration? Ulceration means that the top of the skin has been eroded or it's bleeding, and that the tumor has actually broken through the top layer of the skin, so it puts you into the stage 1B category if you have an ulceration. Again, very, very small melanoma, less than 1 millimeter. However, now you've got some ulceration. Stage 2, and again, it's broken up into A, B, and C. Stage 2 is essentially a melanoma that's between 1 and 2 millimeters and has ulceration, or it's between 2 and 4 and doesn't have ulceration. Again, not really important to talk about the B's, the C's, but stage 3, that's usually where most people come to see a medical oncologist and an oncologic surgeon and talk about, is there anything that we can do to try and prevent this from coming back? Because stage 3 melanoma means that the cancer has spread to nearby lymph nodes. And I like to explain to patients that lymph nodes are very much like the New York City subway system. When you hop on at one station, you can get off at any other station, and there are multiple lymph node stations within your body. So once you get a tumor cell that gets into that lymph node, it now has the freedom to travel. And so we'll be talking about some things that may be useful in trying to prevent melanoma from going to other places. And finally, stage 4 melanoma means that the melanoma has gotten out of the primary area where it started. It's gotten out of the lymph nodes that are really close to where the primary was and has now made a home in other parts of the body. Could be lungs, could be liver, could be lymph nodes, could pretty much be any part of the body, because melanoma really doesn't care where it goes. It just goes where it wants to. And so how do we treat melanoma? Well, it depends on the stage. Some stages of melanoma only need surgery. Some stages of melanoma will need a combination of surgery, immunotherapy, radiation therapy, and most importantly, clinical trials. And clinical trials are something that everyone should consider if faced with stage 3 or higher melanoma. And even some stage 2 melanomas are eligible for our clinical trials. So where are we going with melanoma? Well, we're out of the dark ages of just giving people chemotherapy and saying, well, we hope this is going to work. We're trying to make our treatment for melanoma much more personalized. And so many patients will come to large research centers like NYU and CINJ and Memorial looking for research studies and clinical trials for new drugs that appear to be very promising, because it holds the hope that this can be better than our standard therapy. And so I thought it was important to also talk to you about the stages, the phases of clinical trials, because that can be confusing. So phase 1 trials essentially take a drug and look to see what are the side effects and what is the right dose, and is the medicine safe. A phase 2 trial also continues to look at safety of a drug, but also looks to see how effective is that drug. And if that drug looks like it's very active and very safe in a particular cancer, we then move it on to a phase 3 study, and a phase 3 study takes the standard of care drug, which may be anything from interferon or chemotherapy, and compares it to the new drug. The way phase 3 trials are done, in order to make them the fairest way to test a drug, phase 3 trials are randomized, which means that you don't get to pick which arm of the study you get. Your doctor doesn't get to pick which arm of the study you're in. You say, okay, I'm going to take the chance and enroll in this study because we don't know for sure that this new drug is really better than the standard, so at a minimum, I'm getting the standard of care right now. And that's how phase 3 trials work. And if the new drug is truly better than the old standard, it will replace it as the new gold standard. If, however, the new drug is compared to the old drug and doesn't beat that drug or do any better, the new drug is then abandoned and the old standard continues. So this was on the cover of Time magazine, and the question is, well, is there a magic bullet for melanoma? And the answer is, well, maybe. Because this is one of the pathways, and this is a very busy slide, but this just goes to show how much we're really learning about melanoma and all of the different pathways that melanoma can take in order to metastasize. So we look at these pathways and try to develop targets or roadblocks to block that pathway. One of the most common pathways for melanoma, found in 50% of patients with metastatic disease, is the BRAF pathway. And this is that pathway where if your tumor is trying to get from point A to point B, it goes down this pathway, uses all these enzymes, and the cells will spread. However, if you have what's called a BRAF mutation, we've now been able to develop drugs that will block that mutation and stop tumors from growing. And that's what happens, we block it there. I'm sure Dr. Maynard is going to talk about this type of therapy in more detail in her targeted therapy talk, so I don't want to steal her thunder. But I will show you this. This is a PET scan. For those of you who've never seen a PET scan ideally shows you the outline of a patient's body and then shows you where disease is. And disease is things that are very dark, like this is a lymph node in someone's neck. These dark spots are normal because these are somebody's kidneys because the dye has to get excreted from your body, and so they light up. But if you look at this patient's leg, you're not supposed to have all these black spots on your leg. This is somebody's melanoma that's lighting up on their leg. And look at how quickly this patient had a response. This is 2 weeks later. You no longer see the black spot in their neck, and clearly their leg is much improved. So these are where some of our newer drugs are going. It's providing a lot of hope for where we intend to take melanoma in the near future. And finally, immunotherapy. Immunotherapy is another way that we can try and battle melanoma, and that's by taking the body's immune system and getting the immune system so revved up that we can get it to attack the melanoma that's in the body. Why is that? Well, it's because cancer doesn't allow a normal cell equilibrium. Cancer doesn't care. Cancer is a bully. It just grows wherever it wants to and takes over normal cells. And what happens here is that you've got all these cancer cells, and it pretty much says to the immune system, I really don't care what you do. I'm in charge here. I'm taking over. Well, we're looking at drugs to try and get the immune system back in charge and get to this point again, where the immune system can eliminate or get rid of cancer cells. Well, there's a drug called CTLA-4, which I'm sure Dr. Wolchuk is going to talk about, which essentially tells your body to take the brakes off your immune system. And by taking the brakes off your immune system, your body may be able to identify melanoma tumors and attack them. The problem with taking the brakes off your body's immune system is that we give you immune-related side effects. Those side effects can be rash or diarrhea or itching. Those are the most common ones. But they are controllable, and many patients will derive benefit by getting an immunotherapy such as this. And finally, after you get through your treatment, whether it's immunotherapy, surgery, or radiation therapy, you have to have a follow-up plan. There has to be continued follow-up. The best way to beat melanoma is to stay 2 steps ahead of it. So you need to see your doctors on a regular basis, and that may include your surgeon, your oncologist, and clearly your dermatologist, depending on what stage you are. You have to practice safe sun measures. Got to use sunscreen, you got to use sun protection, you got to stay out of the sun. Some patients may need rehabilitation. Why? Because after a lymph node dissection, they may wind up with some swelling in their arm or their leg, and as a consequence need some physical therapy or some lymphedema therapy to try and move that fluid out of that extremity. And clearly, there's anxiety and there's fear related to melanoma. Even if you're disease-free for a long period of time, there's always that fear that the melanoma may come back. And that's why it's really important to speak to your doctor. You may want to look at alternative ways of dealing with things like yoga, meditation, imagery. All of these complementary things help us to help our patients to better deal with the diagnosis of melanoma. And finally, again, how do we prevent it? Well, you got to use your head. Nobody's going to tell you that you need to be isolated in your house. You just have to use good sunscreen. Don't go to a tanning salon. Don't let your kids go to tanning salons. Don't let your grandchildren go to tanning salons. Pale is the new tan. Education starts with our children, and we have to teach our children that whatever color you're born with is the color that you should be. And so we also like our patients to really practice the ABCDs of ease of melanoma and do their own self-prevention and screening. And finally, I just love this cartoon because this is the kind of hats that we probably all should be wearing. And with that being said, I like to practice what I preach, and I have all my children wear hats when they go outside. And so these are my kids protecting the skin that they're in by wearing a hat, and they took their fur coats outside with them. Thank you. Next, I'd like to introduce Dr. Goidos, who's the director of the Melanoma and Soft Tissue Sarcoma Program at the Cancer Institute of New Jersey, who will talk about surgical therapy of stage 1, 2, and 3 melanoma.